Are you ready to, can you start it? Hi, everyone, and welcome to our November 2023 webinar. We are really excited to have everyone here as we continue on our fall webinar series. Before we kick off and before I introduce tonight's speaker, who it's not going to be as much of an introduction as a reintroduction, I just want to remind everybody that we are having our next meeting on the first Wednesday of December, which is going to be December 6th. We are not having an IAEM meeting in the month of November because it kind of overlaps with Thanksgiving. So as of right now, we will resume in December. So I can give you an update on that at our December webinar. But for right now, plan on that. And again, if you are interested in joining our emergency management club, please feel free to reach out to me. And if you are interested in joining our club, serving on the board, then please definitely reach out to me. And just wanted to throw out there that if you are considering going for your AEM or your CEM, having a position on a emergency management student chapter looks really great. So please really reach out if that's something that you're interested in. So as I said, tonight's guest speaker does not necessarily need an introduction as much as a reintroduction because he is a senior instructor of public health science here at Penn State. He's got a strong background in emergency management and infectious diseases. He's got more than 25 years of experience in leadership, clinical care, education, and research in emergency preparedness and public safety. He spent 14 years at UCLA Health in emergency management, safety, and security, and 8 years as the program director of the Paramedic program, again at UCLA. He has experience as a chief officer in EMS and a paramedic firefighter and critical care paramedic, and he has taught undergraduate clinical and management classes. So his professional interests include improving collaboration and situational awareness across the local, state, federal, and international levels, creation of surge capacity in disasters, and community outreach, including personal preparedness to improve resilience. One of the reasons that I wanted to have him speak to us tonight is because he is going to speak on critical infrastructure and healthcare. That is the topic of one of the core classes that we have here in our public health preparedness option. So in that course, we learn a lot about the fundamentals of this, and Bill is going to be able to talk about it from a boots on the ground perspective and talk about his experiences at Penn State Health and what he sees on a daily basis. So Bill, thank you so much for giving up your evening and speaking with us, and I will turn it over to you.
Great. Thanks so much, Jen. And thank you all for attending and either live or virtually. So as Jen mentioned, she asked me some time ago to engage in some conversation a little bit about critical infrastructure in healthcare organizations. We talk a lot about healthcare as a critical infrastructure. But sometimes we don't always understand the role of critical infrastructure in healthcare. So what does healthcare do for our community? But then on the other side, what do we need in order to facilitate healthcare? And so I wanted to talk a little bit about that in a little bit more detail, try and give you a couple case studies and an overview, and utilize Penn State Health, our Hershey campus, as sort of an opportunity to dig into something a little bit deeper. So we'll hop right into it. So again, as I mentioned, really we want to talk about healthcare as a critical infrastructure versus healthcare needs for critical infrastructure. Okay. So again, talk about the importance of healthcare as critical infrastructure and how that facilitates community resilience. So traditionally, and again, this is something that you may be familiar with, healthcare is defined as one of the 19 critical sectors by the United States federal government, specifically the Department of Homeland Security. And in 2016, there was a large report that came out to define some of the specific opportunities that are utilized by our communities and why healthcare is that critical infrastructure. So if we can't maintain a healthy community, we can't do that based on infectious diseases, as we saw with the pandemic. If we can't do that related to mass casualty types of events, or even long-term chronic illnesses and disease processes. And again, we saw some of this as secondary impacts related to the pandemic. Then a lot of our other opportunities within our communities really fail. So if you look at supply chain, for example, and you saw ebbs and flows in workforce health. So if we don't have a healthy workforce, then things from raw materials to technical industry to shipping and manufacturing, all of those things then suffer. And then every other portion of our critical infrastructure has challenges as well. So healthcare is really that component of not only responding to catastrophic events, but also maintaining health in the first place. So really important, and again, the work that all of you are doing, I think is very important. So when we talk about this, there are sort of sub-factors of healthcare as a critical infrastructure. So again, CISA under Department of Homeland Security really defined this in a few different ways. So in subsectors to include direct patient care. So things such as hospitals, things as long-term care facilities, things such as urgent cares, clinic environments, all those kind of things. It also engaged in health information technology. So we'll get into this a little bit later when we talk about cybersecurity, but the component of how do we maintain that information? How can we utilize that information from one person or one individual, one facility at a time, and ensure that that is shared appropriately to better and more effectively design healthcare and healthcare systems and develop research that really effectively moves healthcare forward. On the other side of that, how do we protect that information so that especially with security-sensitive individuals, heads of industry, politicians, corporate executives, military personnel, how do we ensure that all of that information is safe so that that can't be utilized for other components around espionage or other areas like that? Health plans and payers. So if we look at the component of how do we afford healthcare? How do we ensure that all of the population has that opportunity in order to engage wellness over a longitudinal perspective? And how do we, again, contain costs? How do we look at that so that there is a sustainability of healthcare long term? Mass fatality management. So again, in very significant volumes of fatalities, whether that would be a pandemic or whether that would be large catastrophic types of emergencies, how do we effectively engage in that process? And how do we do that day to day to ensure that we appropriately and sensitively manage fatalities and prevent disease process related to that long-term management? Medical materials, the supply chain sector of that. And there are a number of sensitivities not related to that, from pharmaceuticals to waste streams, as well as radiological sources, other components. And again, how do we maintain those materials, the equipment, the supplies, all of those kind of components as part of that? And then lastly, lab, blood, and pharmaceuticals. Really looking at, again, the infrastructure that is needed in order to effectively test and maintain laboratory engagement, whether that's infectious disease, whether that's toxicological components around radiological or chemical types of events. Blood processing, again, is a big component. How do we do that safely? And then pharmaceuticals. We have such a dependency on pharmaceuticals and the safety of pharmaceuticals. So how do we make sure that, again, from a critical infrastructure protection aspect, we really maintain that safety and security. Within government, we also look at overall public health. How do we, again, put programs together that keep our society and community healthy and respond to, again, community changes? The pandemic has certainly been an overwhelming example of the importance of public health. And then other components around federal programs and responses, whether we talk about things like national disaster medical systems, the utilization of state level, local level, non-governmental agencies that respond significantly in the medical aspect of catastrophic care. So again, all of those kind of components are included in that aspect or that discussion of healthcare as critical infrastructure. So looking at this now from the opposite direction, I want to get into just one example. So our Hershey Medical Center here in Hershey, Pennsylvania, where the College of Medicine is located, want to use this as a case study to really dig into the opposite. How do we determine the needs of healthcare on infrastructure? What is the critical nature of infrastructure, technology, facilities that really support the ability to provide healthcare day to day? So this is our facility here. You can see a nice fall picture here. The superstructure is this whole building here. And we're talking about millions of square feet, and the overall campus being about 550 acres. So very, very large infrastructure. And our facility has about 660 inpatient beds, including neonatal beds. So for Central Pennsylvania, this is a really, really big component of how we support healthcare, especially acute healthcare. But let's go through some facts related to the facility itself. So we have a 550-acre campus. The buildings themselves on the campus spread out over 5 million square feet. We have over 1 million square feet of roofing material. So again, from a overall footprint, so to speak, you can see that. Parking, roadways, sidewalks, walking trails. And if we had to replace this, and this data is a little bit old, this was from about 4 years ago, but the replacement value at that time was about 2.2 billion. So if we look at inflation over the last 4 years, this has probably gone up by maybe 20%. We're talking about construction and industry costs and things. So fairly significant replacement. And our buildings are starting to get older. Over 60% of them are over 25 years of age. So when you start looking at maintenance and replacement and components like that, things start to break down and infrastructure breakdown. So lots and lots of maintenance. A couple other things, and again, this is a few years old, but our annual utility costs were over 12 million. Most of that in electricity, almost 8 million in electricity. But you can see that we are huge utilizers of utilities in general. So when we look at sustainability and our carbon footprint and how we impact climate change and global warming, and how we are engaged in processes for sustainability and global public health, healthcare organizations are not very green. We're doing things all the time to try and change that, but still pretty challenging. And a lot of that is because of some of the nuances that we have to utilize in order for us to sustain very healthy environments, especially in inpatient care and interventional related care. So again, pretty significant. At Hershey Medical Center and then on the campus here, we have a central plant. So it's what's called a cogeneration plant. So we utilize natural gas and methane to create steam. So utilize water, heat that water up with burning or heating natural gas. And in turn, that spins electrical turbines. So we produce a big chunk of our own electricity. Those electrical turbines also create or we utilize some of the steam for steam production. And they also cause centrifugal chillers to function. So we also produce chilled water. And again, we have all of that done inside of that central plant. So it does lots and lots and lots of work. We produce about 1.4 million gallons of chilled water. We have large storage tanks so that, again, from a heating, ventilation, air conditioning perspective, we can maintain temperatures, especially in the summer. We can produce about 8 megawatts of our own electricity. So that's pretty significant. If you look at many small towns, you're talking about that being able to suffice or cover that larger residential area. So again, we do a lot of our own energy production and certainly some of our other utilities on campus. We also have primary and secondary electrical feeds. We have 2 substations that are 69 kilovolts. So redundant feeds in from local PP&L, which is our electricity provider. We also have 31 emergency generators. So when we talk about load shed and engagement, so if we have a catastrophic failure of our plants, our central plant, or we cannot get electricity in from our local substations, there would be a large catastrophic emergency in the local community, like a tornado or very severe winter storm. And again, we lost electrical feeds. We have very significant and stout emergency generation capacity, which is primarily on diesel fuel. So we have large diesel tanks on campus and adjacent to these emergency generators. And we can sustain, on the hospital side, on the critical infrastructure hospitals side, we can sustain about 80% of the building operation or critical operations in emergency power generation for about 7 days. So again, independent if we were completely islanded from the local community and our children's our emergency or sorry, our cogeneration plant was offline, again, we could sustain pretty significantly. We also have lots and lots of other systems. So if you talk about things like air compressors, exhaust fans, building automation systems, so Internet of Things, when you talk about thermostats in individual rooms and other monitors, including fire suppression systems and other things, you're talking about over 150,000 sensors. So pretty significant if you think about, again, not only the maintenance and upkeep, integration of all that, the IT support that's needed, and then the potential if that fails, right? Potential for those concerns if there was a failure of some of those systems or something like a cyber attack. So very significant numbers of, again, engagement there. Question in the chat, building automation system monitor. So JD, did I get that question correct there? So those, again, are all of those things that we monitor, primarily things like heating, ventilation, air conditioning. We also monitor pressure systems. So we'll talk about that a little bit more in a few minutes, but things like negative pressure isolation. So if we have an infectious disease patient, for example, a COVID patient or an Ebola patient or a SARS, original SARS patient, tuberculosis, we have negative pressure isolation, which means that air is drawn in from the outside of the room where that patient is. It comes in from the corridor or the hallway, as well as from, again, inputs into the room itself, but it is negative to the rest of the environment. So air always flows into that room. It doesn't flow out of that room. And then it's sucked up through a return. It goes through a HEPA filter before it's exhausted out into the outside air. So pressure monitoring is another one. We also have positive pressure. So that means that in areas like oncology or surgical environments where we want really, really clean areas, that we don't want air from outside coming in, or outside the room coming in, we bring in fresh air from the outside. We filter it through HEPA filtration first, and then chill it or heat it, or humidify it, and then push it into the room. And that creates a positive relationship to the hallway or corridor or neighboring room. So again, we don't suck any dirty air into that environment. So those kind of things. And then humidity, especially in our operating rooms or other interventional areas where we have high volumes of medical gases, including flammable gases, or oxygen, which is will cause fires to spread more rapidly. We have to maintain humidity, primarily a little bit higher in many cases, so that we don't increase flammability, but also we don't want too much humidity that will cause more components of infectious disease issues. So things like mold buildup, or again, when we have very, very high humidity or dewy types of environments. So again, we want to make sure that we can monitor those things 24/7. Okay. So some other things, recycling and waste products. So again, you can see that our systems are huge waste producers. And it's not just, again, the things that you'd find in a normal residential area. Some of those things, certainly like recycling, that's great. We can take that out, hopefully recycle that in today's markets, and not have a significant negative impact on the environment. But these other components here, these other related things like chemotherapeutics and pathological wastes, pharmaceutical waste, all of that has to be handled in a very specific process. So some of that we treat on site before it leaves here, and some of it we have to pay to have that hauled away and then treated off site. So pharmaceutical waste, for example, a lot of that is incinerated, so that it doesn't go into water sources in our community. So again, if we don't handle that correctly, we can negatively impact the health of the community. So again, lots of complex environments, a very big, heavy lift for our facilities team. So the other thing, again, really is looking at what do we depend on? So we talked about some of these things like energy, transportation systems. How do we get not only our patients and visitors in and out of our healthcare environment, but how do we get our personnel here? In central Pennsylvania, we deal with storms. And in 2011, there was a very severe summer storm, a remnant of a hurricane that came in and caused severe flooding to the Hershey area, and essentially islanded the Hershey campus. So our local McDonald's and Pizza Hut had rainwater and flooding up to their roofs. You couldn't even see inside of them. You saw the tips of the roofs and the signs. And so we couldn't get personnel in and out of the facility. And so for those 400 or 500 or 600 inpatients that we already have here, let alone anyone else in the community that may need emergency services, we really couldn't get people in and out. So how do we create that stabilization and reliance on transportation systems? Water and wastewater systems, we are heavy users of water. We'll talk about process cooling and things here shortly. Communications. How do we engage, especially in emergency communications, to know when we're needed, or if we're calling out to, again, coordinate care to ensure that we have appropriate supply chain, additional equipment, supplies, pharmaceuticals, all those things we're a heavy user of communications. And then certainly emergency services. How do we get a lot of our public health, or our emergency patients in without that reliance on EMS, which we're also a provider of, again, is one of those key areas and sectors that we truly rely on. So to go a little bit more deeply into that critical infrastructure, we actually here at Hershey tier our critical infrastructure systems into 2 tiers. So things that are in tier 1, we really look at trying to have 0 downtime. So in these particular areas, we don't want any single points of failure. So we do a lot of assessment and we build a lot of redundancy into these systems so that we have limited or no downtime based on these processes. So things like steam, which are going to impact our ability to support humidity, to support sterilization, heating water, all of those things that we often need. And then the heating, ventilation, air conditioning system. We use steam in order to blow air by steam-filled pipes and then heat the air. So in our winter months, and right now in central Pennsylvania, it's 40 degrees out. It was 33 this morning, and I was not very happy. But how do we make sure that we keep our environment warm so that, again, we can facilitate appropriate healthcare? Domestic water. We have to have not only a supply of water, but we have to have purity of water. We have to have cleanliness of water. Many of our patients rely heavily on very clean water, whether that would be oncology patients, or we're putting a certain amount of water into what's called reverse osmosis filtration systems. So things like dialysis, where we're taking significant amounts of water, we're processing that in with the individual's bloodstream, and ensuring that we're filtering out additional negative waste products from that person because their kidneys aren't effectively managing that. So there are certain areas like dialysis and our laboratories that require additional treatment of water systems. Elevator conveyance, again, we have very vertical buildings and structures, so being able to move patients into different environments. Emergency power, as I mentioned, some of our, certainly our emergency systems, our lighting systems, many of our medical pieces of medical equipment require constant power. Some of them do have some limited battery backups, but again, without power for a ventilator, for example, it's not going to run for forever without power. We have battery backup that usually lasts about 30 minutes. So again, life-saving equipment is not going to be available if we don't have power. Things like medical vacuum for suction of patients, nurse call systems, so when we have emergencies in a particular room, bulk oxygen, bulk other medical gases, chilled water. And chilled water is really, really important, especially in summer conditions. And with the presence of many electronic devices, especially our IT systems, they're massive generators of heat. So even in winter months, we end up chilling or again, modifying the temperature in some of our IT structures or IT infrastructures. And without that, we would burn those devices up very quickly and have catastrophic failures very quickly. Building automation systems, again, the integration and balancing of all of the different loads and sensors within the system. Our communication systems from telephony to cellular to Wi-Fi systems, all those things. And then information technology. We are so heavily reliant on things like the electronic health record and everything that we bolt onto that or create interfaces with that. So pieces of technology like MRI machines or CT scanners or laboratory analyzers that now have direct integration into the electronic health record. So without that infrastructure, it's not that we can't provide care, but the safety and efficiency of that care suffers drastically. So again, from an uptime perspective, we really want to look at how do we create as much resilience as possible. Other things, again, tier 2, that again, we can have some downtime with, and it won't negatively impact patient care or provision of healthcare. But if we don't have it for long, or we don't practice backup systems, it can create negative impacts. So things like our natural gas feeds, fire sprinklers, fire pumps, and fire detection systems, HVAC, overall HVAC system, it is critical. But again, sometimes we have things like fans, we can open windows, we can utilize some backup mechanisms with that. Our normal power system, again, we have resilience with backup power systems, sewage ejection, storm drains, and then our physical security infrastructure. Again, lots and lots and lots of technology that go into all of these things. So I want to run through a couple case studies with you. So one is our oxygen system. So at Hershey, we have, again, significant amount of buildings, about 5 million square feet of infrastructure. So we actually have 2 different oxygen tank farms that are in different parts of the campus to create that backup, create that resilience. So each tank farm stores about 14,000 gallons of oxygen in both primary and secondary tanks. So resilience on top of resilience. And with those tanks full, we have about 19 days of capacity between the 2 farms. And they operate independently, but the infrastructure is tied together. So the feeds come in at different components into the building. So if one of those feeds was impacted by construction issue, or when I was in California, we worried a lot about earthquakes, but there was some other issue that impacted that the pipe system, then the other tank farm could continue to support and supply the rest of the building. So as long as we could get that turned off or that feed controlled, then we could continue to service in a loop the rest of the organization. So about 2 miles of piping that is in the system as well. So you can imagine if we had some penetration or a small hole in a pipe, there are lots of shutoff valves, so we can try and control that. But again, that could have significant consequences. So big systems throughout the organization. And here are just some slides of what our tank farms look like. So the product comes in as a liquid product, comes in from one of our distributors. We refill the primary and secondary tanks, and then it goes through a system that allows it to convert from a liquid to a gas, okay? And then once it goes into gas form, then it feeds under pressure into that piping system that is at, again, these 2 different locations, and causes pressurization of the pipes into the hospital itself. We also have some redundancy that allows us to bring temporary evaporators in. So we have some emergency connections. So if the tank farms failed, or if we had simultaneous emergencies, or we couldn't get those feeds in for whatever reason, we have backup areas that we can bring a vendor in with liquid oxygen and a portable evaporation system. And when we have to supplement our amount of oxygen, like we had to in COVID, this was a strategy at many hospitals, again, in order to improve the amount of or volume of oxygen that was available within the systems. So this is what this looks like. They bring it in on a trailer mounted supply system that again has a supply of a liquid oxygen, and then the evaporator, so it allows the liquid to go into this device, and when it comes out the other side, it is now in a gaseous form. It warms that liquid. Okay. So that's again just one case study there of the complexity or the layers of assessment that we do in order to assess vulnerability, and then look for redundancies to provide something that's very, very critical when we talk about healthcare. So where are the vulnerabilities? So in facilities, as I mentioned, water is one of those big areas. So process cooling, we are huge hogs of water in that we have so many devices that churn and pump and do other things. And when they're doing that under load, they produce lots and lots of heat. So we have to keep those pumps and those devices and those rooms colder. So without water, we have a challenge in doing that. Power, we have significant dependencies on power because so much of our equipment relies on power to work. Again, whether it's medical devices or radiological equipment, lab analyzers, our computer systems, lights, elevators, all of those things require power. So again, very significant dependencies. If we lost all power sources, we would have a very challenging time maintaining patient care. And then steam, and we talked about this a little bit before, things like hot water, humidity, pressure, sterilization. Without that, again, creating an environment that is appropriate for most inpatient or interventional healthcare is challenging. On the other side, with IT and IS, we also have some very significant vulnerabilities. Across the United States, we're seeing large amounts of cyber attacks on the healthcare sector, including ransomware. We're going to talk about a case study here in a few minutes related to that. We also have challenges with communication failures and telephony. Again, so many of those systems now are reliant on network connectivity. Very few organizations have old copper lines or POTS lines that allow for communication to come in and out of organizations. So we're very reliant on networked communications. Network disruptions and Wi-Fi. So even standard connections, so much of our service is software as a service over the internet. So it may not be present, we may not be doing the computer work inside of our organization. We have applications that are built and all of the processing is done somewhere in the cloud somewhere. So if we don't have that ability to have network connectivity, we can create significant dysfunction. Medical device integration. So again, a lot of the equipment, when we talk about physiological monitoring, like an EKG monitor, that sits in a room that is hardwired into a patient. We have wires that connect to their chest. With that integration, and now everything is online. Everything, all of that data is digital and flows through systems. So if there's problems with the equipment itself or the connectivity or the integration with the electronic health record, then that data becomes very compromised. And then things like our radiology lab and pharmacy areas, heavy reliance on digital technology. And again, its ability to communicate with outside systems for reporting, but also even before reporting, just even getting that order in. How do we determine what laboratory study needs to be done or what imaging study needs to be done? Without that connectivity into the electronic health record, we can have significant challenges and certainly loss of efficiency and safety concerns with that as well. So just another briefing or case study here related to cyber. And again, I know that there's a lot of coverage related to cybersecurity across public health preparedness, as well as many other critical infrastructure sectors. But just to give you some healthcare related components here. So ransomware, for example, just as one opportunity within cybersecurity issues. In the state of Pennsylvania in 2000, we led all other states and had over more than 5 million in losses, spread across 116 different victims, primarily businesses. And in 2020, over 10,000 reported attacks in the state, again, 100 million of losses, and projected growth of over 69% by the end of 2021 when some of this data came out. So these are all according to federal reports. Now, what we know about this is that these reports are probably underreported. Many organizations, for liability reasons or concerns over liability, not actual liability, have concerns about cyber disruptions and attacks. But And so engaging the federal government or reporting them in as criminal activity doesn't always exist. In 2020, there was also 26.7 million individuals that had HIPAA protected data leaked. So again, when we talk about espionage, when we talk about, other concerns related to both healthcare information, but also billing information, et cetera, all of that is very concerning. And major attacks across many significant healthcare organizations in 2020, 21, and now 22 and 23. So seeing, again, an uptick. President actually came out last year, or the White House came out last year. We've seen a lot more regulatory concern related to the impacts of ransomware and cybersecurity. So to give you a case study, in 2021 in May, Scripps Health in San Diego County was impacted for 25 days. So again, over 3 weeks that they were essentially completely down. So this resulted in emergency room diversions for 5 hospitals, 4 of them being major academic medical centers. So trauma centers, transplantation centers, pediatrics and children's hospitals, significant stroke and heart attack centers, where again, all of those patients had to be brought to different facilities within the county of San Diego or beyond. And so you can imagine the strain that that put on the entire system there. So significant impacts to community health during those 25 days. The impact included the electronic health record, the patient portal, email, network connectivity, internal and external facing websites, voice over IP phone service, imaging and telemetry equipment, SCADA, which is again our infrastructure interfaces, including the elevator controls, were out of service, payroll and financial. So how do you pay your employees? How do you order product? How do you order supplies, et cetera? Internal emergency communication systems and offsite backup servers were all impacted. And again, some of this data is being very heavily protected as far as the impact, but there were already, again, about 6 months ago, there were already 150,000 patients that were suing in class action lawsuits for breaches of privacy, and then other lawsuits related to operational interruption for patient care. And then they believe that there was as much as $112 or $113 million in revenue loss based on, again, the loss of patient volumes during that month. And they're only expecting to receive about $14 million in insurance and business continuity insurance. So you can imagine, again, the financial stresses that it puts on this healthcare network. Okay. So other things, again, very significantly vulnerable on holiday and weekends when there's not as much administration around or not as much support. Unable to infiltrate through work emails. They fish through personal employee emails, increase in sophistication and severity, many cyber gangs that may be state sponsored, and again, other things like cyber cartels where people can go out and hire individuals or organizations to go and attack for various different purposes, different types of businesses or organizations. And again, if we look at across the United States, it's estimated that we paid almost $2 billion in cyber attack ransom, and demands have been increasing over time. And again, in the healthcare sector, we continue to see more and more prevalence and significant impacts to healthcare organizations. So within our Penn State Health and Milton Hershey Medical Center, IT outage and communication and telephony outage is very high on our hazard vulnerability analysis. One, because of probability that's existing not only inside of our systems, but within our partner institutions. but also, again, the impact that it would have to patient care, as well as brand and reputation, and again, overall infrastructure. So very significant concern. And as I mentioned back in May of 2021, the White House did initiate a pretty significant executive order to look at how healthcare could be supported related to ransomware attacks. So trying to, again, identify resources for a community. So in sort of summary related to critical infrastructure and healthcare, we not only have, again, a responsibility to try and be as resilient as possible to support our communities, but we also need to understand the complexity of that, the complexity of what it takes to go in order to providing quality and safe and effective and cost-effective healthcare. And we have heavy reliance on infrastructure, heavy reliance on utility systems, heavy reliance on space, IT, communication systems in order to be effective. So that is, again, the opportunity there really to help understand and look for single points of failure so that we can build resilience, so that, again, we not only have resilience for the delivery of individualized healthcare, but more systemically and global healthcare in our communities and in our nation and our world. So again, lots of complexities there, lots of opportunities to continue to harden and create more resilience. So I will stop there, and if there's any questions, I'm happy to take any of those, and all of my contact information is there. So for those folks that are online watching this at some other point, if you have questions or concerns or observations, please feel free to reach out and be happy to interact with you and try and support you in any way that I can.
Thank you so much, Bill. We do have a couple questions. JD, do you want to ask them, or do you want me to read what you typed?
Sure. So in the oxygen tanks, you said you had 19 days of storage. Does that number fluctuate? I mean, does it, like, at what point did you top off the tanks?
So we get deliveries typically once a week. So again, it's on a scheduled delivery pattern. So we have tankers that come in and fill it up. So typically we don't allow it to go less than 12. But again, some of that may fluctuate based on demand. So if there's a really, really heavy demand, we have high patient volumes and very, very high acuity, that may fall down to 8 days or something, even though it's been filled in the last 7. Or in other circumstances, it may not fall below 12. We have relatively low acuities, but we create consistent cycles for delivery. But then if there are big fluctuations for whatever reason, we can get more on-demand filling as well.
Cool. In the 3 highest threats you listed, you said workplace violence was the second. Do violent events happen that much?
Yeah, so unfortunately in healthcare, one of the biggest concerns related to our workforce and not only acute events, but also sort of chronic events and creating burnout and loss of workforce is workplace violence. And this is really not just at Penn State Health, this is systemic across the healthcare industry. So those can be things as what are perceived to be very benign things like verbal threats to very significant physical threats, battery, or ultra violence, where healthcare employees are stabbed or shot and killed in the environment. So it's not, the very, very severe violence is not particularly common, but the underlying assaults and batteries that occur on a day-to-day basis across the United States are very significant. So that is one of those areas that we do have a lot of concern for, not just, again, in those hyper acute situations, but systemic and long-term.
How do you were you asking something, JD?
Go ahead.
I was gonna say, did you see that increase a lot during COVID, or was it kind of like on a trajectory anyway?
Yeah, if you look at the data nationally, prior to COVID, it was definitely on an uptick. And you've seen a number of states that have initiated healthcare related workplace violence laws. Where I used to work in California, it's one of the most highly regulated or demanding as far as organizationally to try and protect healthcare employees. Mandated reporting within 24 hours on any physical violence, investigatory processes, action plans, and now you're seeing, and that was back in the mid 2000s and 2010, 12, 15, there was escalations of that out in California. And now you're starting to see in January of 22, the Joint Commission, so one of our large regulatory bodies, put out very stringent workplace violence prevention regulations to mandate that healthcare organizations really take this much more seriously and are looking to proactively put in place mitigation factors to try and reduce the prevalence of workplace violence.
Why do you think, and we talked about this in 810 as one of the topics, why do you think that like the Joint Commission had to put in place such stringent standards? Like, was there kind of pushback from the field where people didn't want to admit it was a problem, and people that were being attacked just didn't want to, like, this is part of the job, I'm not going to say anything, I don't want to be looked at like as a complainer?
Yeah, I mean, I think that's part of it, right? But if you look at regulatory bodies in general, there's always a pushback, and we have the limited good of money, and so if everything's a problem and we have to spend money on everything, then there's not going to be opportunities for different growth and development and other things. So I think that's where you do get pushback from leaders across healthcare organizations. But at the same time, I think many internal organizations were really looking at this as a critical problem. But I would compare it to some of the other regulatory components that we've seen in CMS, for example, the Center for Medicaid and Medicare Services, related to long-term care facilities. For years and years and years, long-term care facilities in places like Florida, there was no mandate to have emergency power generation. So you had a hurricane, you had a severe storm, and now you lost power. And now you had very humid and hot conditions where you saw, residents of that long-term care facility suffer and even die because of the lack of capacity for heating, ventilation, air conditioning systems. And that was all due to a lack of investment in infrastructure and emergency power capability. So you've seen that shift occur on a national level. Same thing after Katrina. If you look at the regulatory environment from CMS and areas like Joint Commission that occurred after Katrina, there were very few emergency management standards that existed for healthcare prior to Katrina. In 2007, they went from like 3 to 81, right? And then in 2008, emergency management was moved out of another set of standards and became its own set of standards. And it's continued to evolve ever since. So again, I think unfortunately, sometimes catastrophe and disaster or critical events, sentinel events, really drive regulation. And again, some organizations are far ahead of that. They're assessing risk differently, and some of them, unfortunately, either do not assess or don't sense risk the same way, or don't feel like they have the ability to invest in mitigation the same way.
Thanks. We have another question in the chat. When you were talking about the cyber attacks, you showed that Pennsylvania had gotten some pretty significant losses. Do we know why Pennsylvania was up so high?
I don't, and again, some of that may be related to some of the infrastructure that exists. So when we talk about the military industrial complex, when we talk about components of industry, agriculture, higher education, healthcare, lots of different things, and Pennsylvania being a pretty large state as well. I think that, again, the complexity of it, the geography, if you go from Western Pennsylvania to Eastern Pennsylvania and you have so much significant diversity in a large geographical and complex environment, I think that there's likely some engagement around that. But why it's higher than other states like New York or California or other things, I don't know.
I'm sure a lot of people are asking that question as well.
Yep.
All right, well, it is 9:01. Does anybody else have any questions? I don't see anything in the chat, and I don't see any hands raised. So, Bill, thank you again for speaking tonight. This was so much great information, and I really, really appreciate you taking the time to talk to us tonight.
Great. Well, wonderful. Thanks so much, everyone, and best wishes. And if I can be of any support, please don't hesitate to give me a ring. Thanks so much.
Thank you so much. We will see everyone
Thanks,
in
Bill.
December.
Take care.